All right, hello and welcome again to our STI Expert Hour webinar focused on adolescent sexual health. The topic is supporting adolescent sexual well-being and health through teen-centered care, and our STI Expert Hour speaker is Dr. Claudia Borzutzky, who we're very happy to have. My name is Dr. Kelly Johnson. I'm the Medical Director for the California Prevention Training Center at UCSF, or the University of California, San Francisco. I'll be emceeing today's webinar and going over a few housekeeping introductory slides right here at the beginning, and then we'll get into our talk for the day. Both Dr. Borzutzky and I are going to be off camera while we speak just to save bandwidth, but we'll be back at the end for Q&A. Okay, so first, a little bit more about the California Prevention Training Center, or CAPTC, at UCSF. As some of you may know, if you've been to our trainings before, we're a multidisciplinary training and capacity building assistance center. Our STI clinical training is sponsored by the Centers for Disease Control and Prevention, or CDC, and we're a member of a national network of other STD clinical prevention training centers called the NNPTC. What do we do? Well, we provide virtual and in-person trainings, technical assistance, clinical tools, and STI clinical consultation services, focusing on complex STI issues in patient care. You can learn more about CAPTC at UCSF and the network of which we're a part by visiting the web pages on this slide. The CAPTC also runs this tool that I really want to tell you all about. This is the STD Clinical Consultation Network, or STD-CCN. We run this for our region. This is an online clinical consultation network where providers can go, submit your complex STI patient care questions, and our faculty, who are subject matter experts, will reply to your question either by phone or email, whichever you prefer, within 1 to 5 business days, again, whichever you prefer. This is a really helpful resource, and we hope you'll check it out. Now to our webinar. This is our financial disclosure. We have nothing to disclose. And here is our CME disclosure for today, stating that today's webinar will be offered at 1.5 CME units at no cost to you. Now, to earn those 1.5 CME units, here are the requirements. So you must have registered on the NNPTC site for this webinar by 3 p.m. Pacific yesterday. You must attend today's webinar live and in full. Attendance will be recorded as you sign on to the webinar. And just so you know, we're unfortunately unable to issue CME for attending just a portion of this webinar, or if you're viewing this webinar after the fact as a recording. Finally, you must also complete the post-course survey evaluation, and the deadline for completing that evaluation is on the slide here, December 11th, 2024. The evaluation survey will be sent out 24 hours after the webinar, and it will come from the email address training@nnptc.org. So you'll get an email notification with a link to complete your post-course survey. Again, that email will come from training@nnptc.org, and it will go to the same email address that you used to register for today's webinar on the NNPTC site. To make sure you get this email with your post-course survey evaluation, please do add training@nnptc.org to your safe and trusted senders list, and be sure to monitor your inbox and your spam and junk folders for this notification. If you do meet our CME requirements, you will receive CME notification by January 10th of next year, 2025, and this will come from a different email address, which is us, captc@ucsf.edu. This email will have a claim link and instructions for obtaining your certificate through our CME provider, which is the University of Nevada, Reno School of Medicine. Again, the CME notification email will be sent to the same email address that you used to register for today's webinar. And please make sure you also add captc@ucsf.edu to your safe and trusted senders lists. And we get a lot of questions about this, so just so you know, in about 2 weeks after today's webinar, you will receive the post-course materials notification from captc@ucsf.edu, and this email will have a link to the webinar recording, the slide handout, some reminders about CMEs, and any other available materials. You don't need to request these materials separately. They will just come to you. Again, this will come in an email to the same email address that you used to register for today's talk. Now, I think we're all pretty familiar with Zoom at this point, but just a couple of quick housekeeping notes for today. So the Q&A will be turned on for attendees, but the microphone, video, and the chat function will be turned off. To use the Q&A, click on that Q&A icon that you see in the middle of this slide here. It's located at the bottom of your Zoom screen. And once you click on that Q&A icon, you can type in your question and, of course, click Send to submit it. If you want to submit your question anonymously, just select Anonymous. You can submit questions up until the last 2 minutes of the Q&A section. Now, during the webinar, I'll be reviewing the Q&A and I may answer your questions directly in the Q&A box, or we may choose to answer them live during the Q&A section after our talk today. If you have administrative questions, you can also put those into the Q&A and they will be answered by our clinical administrative team of Elizabeth Olson and Lauren Blakely. If you have any questions about today's webinar, please reach out to Elizabeth Olson, who is our clinical program manager. Her email address is what you see on the slide here. And now, without further ado, I'd like to introduce our STI Expert Hour webinar speaker today. Dr. Claudia Borzutzky received her BS from UC Berkeley and her MD from the UCLA School of Medicine. She completed her family medicine residency at Harbor UCLA Medical Center. And since completing her adolescent medicine fellowship at Children's Hospital Los Angeles in 2005, she has focused her clinical practice and research on adolescent and young adult sexual and reproductive health. She's a medical director at Planned Parenthood Los Angeles, and congratulations, she was recently appointed as chief of the Division of Adolescent and Young Adult Medicine at Children's Hospital in Los Angeles. We're fortunate enough to have Claudia speak to us in the past in 2016, and we're very, very pleased that we can offer this update today. So thank you for being here, and I will turn it over to you now, Claudia.
Thank you, Kelly. Let me make sure I have things set up properly. Let's see. Are you seeing my correct screen?
Yes, looks good.
All right, great. Well, thank you so much, everyone, for being here today. I am going to be talking about one of my favorite topics, adolescent sexual well-being. This will be sort of a whirlwind tour through what I think are important concepts and aspects of adolescent sexual well-being and health. We will hopefully cover lots of ground in a way that feels meaningful for all of you. And I'll definitely be happy to take questions at the end, like Kelly said. So, excuse me. On that note, here are our learning objectives for today. Hopefully by the end of the talk, you'll be able to integrate an understanding of adolescent consent and confidentiality and related resources you can use in order to optimize your practice and lower barriers to care. You'll be able to explain the difference between risk reduction and the promotion of well-being in the context of adolescent sexual health. You'll be able to employ knowledge of adolescent STI rates and teen pregnancy trends in your clinical practice. And you'll be able to describe teen-centered approaches to promotion of sexual well-being and reducing rates of STIs and undesired pregnancies. I do not have any disclosures to share. So for this next slide, we're hoping to get a little input from all of you. So I know who we're talking to. If you could please answer this poll and tell us where you're from or really where you are practicing, that would be great. We'll give everybody a few seconds. Let's see how our results looking. Can we display our results? All right, so we have a big group from California and some folks sprinkled throughout. It looks like the rest of the country, which is great. All right, next question. You ready for the next poll? Let us know where you see teens. If you see teens, you see them primarily in a primary care setting, a pediatric or family medicine clinic, for example, or private practice, or are you seeing them in a more of a dedicated sexual health setting, like a family planning clinic or STI clinic? All right, we have results for that one. So it looks like about 80% of folks are seeing patients, excuse me, in a sexual health setting and about 20% in primary care. Great. All right, thank you. And our last question is about how often you see teens. Would you say you see teens rarely or frequently in your practice? All right, let's see our results for that one. Looks like a little more than half of you are seeing teens frequently, which is great, and about 40% rarely. So great. Well, thank you so much for answering those questions. That'll just help me orient myself a little bit to who's here. And hopefully we will be able to bridge kind of information that will help everybody who is attending. So I wanted to talk for a minute about why I think it's so important to focus on adolescent health in general and their sexual and reproductive health in particular. So this time is really a time when lifelong habits are explored and maybe established. And it really creates a unique window for education, for contact with healthcare providers, and for interventions that can really change a life. It's also a great opportunity to fulfill adolescents' often overlooked need for healthcare, especially reproductive or sexual healthcare, and to advocate on their behalf. It's just a time of very exciting but potentially overwhelming rapid change and growth. And that can be overwhelming for both the young person and their caregivers, and they really can benefit from extra support. And I'm personally a parent of three teenagers, so I really am feeling all of this personally right now. And probably some of you are as well. And the other thing I'd like to say, obviously, I love teenagers. That's why I went into adolescent medicine. But I think taking care of teens is really fun. They can be really funny, and they really, really love having adults that will talk to them openly and honestly about important issues. So hopefully you all share that with me. All right, the next thing I just wanted you all just to think about, we're not going to do a poll for this, but what do you think of when you think about adolescent sexuality? And you know, our society has a lot of real mixed messages about adolescent sexuality. It's taboo. It's, you know, for certain cultural religious reasons, it's not accepted. There's shame associated with it in some people. And then we're just messaged constantly all the time from media and other sources about how sexual adolescents are, right? For the good and the bad. So let's think about, as you consider your response to that question, what's typical? What is normal? And thinking a little bit through a developmental lens. So as I'm sure you all know, teens are really, they're not just big children and they're not little adults. It's a time when they are going through changes biologically, cognitively, emotionally, socially, and of their sexuality. So we sort of tend to group adolescents into three different phases or age groups. And these are rough age groups. Of course, it's different for everybody. But for early adolescents between the ages of 11 and 14, physically, they're going through their growth spurt, they're going through puberty, they're developing secondary sexual characteristics and typically becoming much more sort of self-conscious about their body. Cognitively and socially, they're still pretty concrete thinkers, especially at the beginning of that phase. They're beginning to understand hypotheticals and be able to think a little bit more abstractly, and starting to develop a little more independence from their parents. And there's still a big emphasis on fitting in. In terms of their sexuality development, crushes are very common at this age. Some young people in this phase may start to have romantic relationships, and sometimes that can include sexual behaviors. Middle adolescence, we think of sort of between 15 and 17 years of age. This is when puberty starts to be completed, especially for cisgender females who are usually reaching sort of their adult height during this time. Cognitively, they can start to be more reflective and think a little bit more abstractly. They're starting to develop a stronger sense of their own identity. And there's definitely an increased inclination during this time towards risk taking. And that's normal. That's part of how we learn to explore the world. If nobody took any risks, they would never leave the house. So this is a really important part of development. But of course, we want to think about how to scaffold our young people as they are experimenting. In terms of sexuality development, masturbation, sexual encounters with others, and romantic relationships become more common during this time. And according to the last data we have from the National Survey of Family Growth, by the end of this phase, about 25% of youth have had sex, and the NSFG defines that as penile vaginal intercourse. Late adolescents, 18, 19-year-olds, at this point, their body is reaching its adult appearance. Most males are starting to reach their adult height. They really, in terms of their cognitive and social development, can really empathize a lot more deeply by this time. They're more aware of their own thought processes and kind of can have more insight about themselves. Their identity is starting to really individuate more away sort of from their friends and parents. Not that those aren't important to them, but they're kind of developing their more own distinct values, and that value system is maturing and stabilizing a little more. And by the end of this phase, about 60%, according to the NSFG, of young people have had penile vaginal intercourse. And by the end of this phase, about 15% of cisgender females and about 3% of cisgender males report that they've had a sexual experience with a same-sex partner, although most of those have previously had a sexual experience with an opposite-sex partner. That often happens first. So as we can see, sexuality really can manifest during any of these phases in different ways. And for some people, it's later. Some people really, and some people are asexual, but if they have, sexuality and sexual behaviors, it may be later for some folks. And also I think it's important to remember that risk-taking behavior does become more modulated over time. And some of you have probably seen those images of brain development and how the frontal lobe is really the last one to develop. That's usually, for most people in the mid-20s, and sort of the communication systems between the different parts of the brain that modulate risk-taking also are maturing during that time. So things are changing. All right, so why focus on adolescent sexual well-being? As opposed to thinking, we think about sexual health, risk reduction. Well, sexual well-being really centers a sex-positive approach, and it inverts the kind of risk-based paradigm that many of us kind of grew up thinking about this domain in, that really confers shame on teens who are sexual, young people in general. And though abstaining from sexual intercourse may reduce certain health risks, abstinence-focused approaches, many of you probably know, have been proven to be quite ineffective when it comes to public health outcomes. And the countries with the best sexual health-related public health outcomes really promote a sort of general societal acceptance of adolescent sexual relationships. They provide youth with comprehensive information about sexuality, and they provide clear expectations about and clear instructions for preventing undesired pregnancy and STIs. Dr. Dennis Fortenberry, who's an adolescent medicine scholar and has studied sexuality among adolescents for years, has written about sexual well-being, and he describes these different domains that I think are really useful to think about. So he talks about domains of sexual self-esteem, so perceptions of worth and attractiveness as a sexual person, sexual self-efficacy, perceived control in sexual situations, including the ability to consent or refuse it, and sexual arousal and desire and pleasure. And though these topics are so intrinsic arousal, desire, and pleasure to adult sexuality and related research about adult sexuality, they're almost never addressed when it comes to adolescents and their sex lives. And this is really, we're doing a disservice to teens when we're sort of not acknowledging that this is part of their sexuality to development as well. And when we kind of only focus, and use a language of danger and warning and avoidance, we're really not supporting this positive aspect of their lives. I also really like this graphic depiction of this framework, competency-based framework of sexual well-being for adolescents on the left, that, as we talked about before, while kids are going through these different phases of development, they can also achieve these different competencies that are going to help them have sexual well-being, including sexual literacy and gender equality attitudes and coping skills, interpersonal skills. So I think it's good to think about the patient in front of us through these different lenses. There are so many factors that affect sexual health and well-being, and I think we often only think about the individual parts that are affecting someone's choices. But I think it can be really helpful to look through an ecological sort of lens at our patients and what things may be helping or hindering their ability to achieve sexual well-being. So if we think about the individual level, these are things we've probably all learned about before: biological factors that might make a teen more susceptible to STIs, other chronic medical conditions, mental health and history of trauma, substance use, their gender identity, their cognitive developmental stage, and their sexual orientation. If we go a little farther out to the interpersonal, family, friends, partner level, we're looking at family closeness, which has been demonstrated to affect sexual well-being and outcomes, cultural and religious norms, a family's immigration status and their willingness to sort of be out in the community and use services, their social economic status and resources, a young person's peer group norms, and then their partner communication and openness. The next level out, if we think about schools and education systems, school belonging and connectedness is also something that's been demonstrated in research to improve sexual and other health outcomes in teens. What's going on in the school in terms of academic resources, expectations of young people, what they are what they're able to do in terms of academic performance in their school, and then what sexual health education their school or education system is providing for them. The next level out, we look at the community. Neighborhood cohesion and safety has been shown in lots of different research to affect adolescent health outcomes, including sexual health outcomes, availability of sexual health services in the community, availability of emergency contraception in pharmacies, condoms. The next level out, we look at more macro societal or structural factors, including access to equitable housing and healthcare in general, that sort of transmission intergenerationally of wealth and poverty, and how much different communities are experiencing forms of discrimination such as racism, homophobia, xenophobia, especially with our political environment today. More macro, we get into environmental and global level. Climate change, war, and migration, of course, impact the ability of teens to make healthy choices, any kind of choices, and have agency in their lives. And of course, that will impact their sexual and reproductive health. COVID, pandemics that we've seen, COVID in particular, and how it impacted our ability to access health services in general, which we'll talk about a little bit more. And then I wasn't quite sure what level to put social media in, but I think we all know that social media and just, access to online information has really impacted our teens in lots and lots of different ways. And we'll talk about that a little bit more as well. So, as you can see, this has become a very busy slide as I've gone through it, but I think that when we consider our teens' contexts more broadly than the sort of actual choices, good or bad, as we may see them in the moment that they're in a sexual encounter, we'll be able to really provide more effective support and care to them. So how can we, from that context, begin to comprehensively and accurately assess the sexual health and well-being landscape of our teen patients. So first, let's consider the very foundational concept in adolescent healthcare of consent and confidentiality. As many of you probably know, the importance of confidentiality to adolescent healthcare has been demonstrated in many studies over the last 25 and more years. And consequently, many professional societies have asserted the importance of confidentiality in adolescent care. And as you can see here, some of them include the American Academy of Pediatrics, ACOG, OBGYNs, the Society for Adolescent Health and Medicine. And I just wanted to put this as a more recent study because some of the other studies about consent and confidentiality really go back to the 90s. But there was a study in the MMWR, you can see here, that reported that about 13% of sexually experienced adolescents and young adults on their parents' insurance would not seek sexual reproductive health care due to confidentiality concerns. The highest rates of that was among 15 to 17-year-olds. About 23% of them said they would not seek that kind of care due to concerns about, their parents finding out. And those same persons reported lower rates of receiving certain STI services. But on the flip side, the rates were higher for those who had time alone with their provider. So really important for us to make sure, especially in those primary care settings where you might be seeing kids with their families, to establish kind of that it's normal to see teenagers starting around age 12 on their own for part of the visit without their parents, and make sure that both the kid and the family is aware of confidentiality sort of regulations in your state or jurisdiction, and make sure you're aware of them because they vary quite a lot. So especially if you move from one state to another, it's really important to find out sort of the details. And talking about confidentiality with teens and their families really will increase the likelihood they will share openly with you and let you help them with the things that you can. So just looking kind of broadly across the United States, as you know, we have highly variable laws around reproductive health care in our country. And if we look, this I put together recently, so some of these laws are changing very rapidly, as you know, in different states, but this is from Guttmacher, which is a great resource about reproductive health care. At this time, when I did this a few days ago, for contraception, 27 states and the District of Columbia explicitly allowed all youth to consent to contraceptive services, or they allow youth under 18 at a specified age and older to consent. And we'll look at California as an example of that. All states and DC allow young people to consent to STI and HIV services. 39 states and DC allow it at any age, and the remaining states allow certain categories of minor age groups, for example, 12 and up or 14 and up. And then 18 states allow, but do not require a provider to inform parents when they deem it in the patient's best interest, whether or not the patient gives consent to that. The provider can inform their parents. For prenatal care, about 33 states and DC at the time of I made this slide, explicitly allow all youth, any age, to consent to prenatal care. And 14 of those states allow but do not require a provider to inform parents with or without the teen's consent. For abortion, as we know, this landscape is changing very rapidly. 2 states in DC explicitly allow individuals to consent to abortion services regardless of age. 20 states require parental consent before a minor can obtain an abortion. 10 states require prior notification of at least one parent, and 6 states require both notification of and consent from a parent before a minor's abortion. And that's, of course, in the context of whatever regulatory laws have been passed in that state for abortion and how far along in a pregnancy one can have an abortion. If you're not sure about the regulations in your own state, I wanted to share this really excellent resource at teenhealthlaw.org. I don't have a live version of this, but this is an interactive page. And if you go to the webpage and you click on your state, it will give you a compendium of your state's laws and federal laws that may impact your patient's healthcare decisions, both sexual and reproductive health and other domains. It's really awesome. So just as an example, and since many of you are here in California, real quick, we can go through the broad sort of strokes of adolescent consent laws here in California. So here, minors of any age can consent to pregnancy-related services. So that's abortion, birth control, with the exception of permanent sterilization, and then diagnosis and treatment of a pregnancy. Minors 12 and older can consent to care for STIs. So that's prevention, diagnosis, and treatment of STIs. That also means, even though it can be complicated sometimes logistically, that a minor could consent to their own HPV vaccine, hepatitis B vaccine. If a parent, for whatever reason, didn't want to, the minor can consent to that themselves. HIV testing, also 12 and older. Services around rape can be consented by minors 12 and older. And then federally funded drug counseling, minors 12 and older can consent. And for all of those things I just mentioned, in California, providers are not allowed to notify parents without the consent of the minor. Then for state-funded substance use treatment and for outpatient mental health treatment, minors 12 years and older can consent, but parents are, it is required to involve parents unless the provider thinks that the parent will interfere with the treatment or harm will come to the patient if the parent is involved. And then sexual assault, which is defined differently in the codes from rape, minors of any age can consent. And again, parents are supposed to be involved and notified unless there is a concern that the parent was involved or with the sexual assault or would make the problem worse. So coming to adolescent-friendly services, why is it so important for us to make our services youth-friendly? And this is a great graphic from the CDC you can look at when you get the slide set, features that make a service youth-friendly. So services that are not youth-friendly, as I'm sure you can all imagine, can lead young people to not share important details about their health or behavior. They may end up leaving the clinic or nurse's office without getting the care they need. They may choose not to follow through with treatments based on how they were counseled about those treatments. And they may refuse or forget follow-up care as well. So the next section of the talk is really kind of helping us frame how we can create an environment for those services and what we need to be aware of. So again, just thinking developmentally and what the patient in front of us is sort of where they might fall along these spectrums. So this chart on the left is from that National Survey of Family Growth, and you can see that there's a pretty linear relationship between age and when patients have sex for the first time. And by the time, someone is about 17 and a half, there is about a 50-50 chance that they've already had sex for the first time. The bar graph on the right is from the Trevor Project and shows when young people who identify as LGBTQ first came out, and they interviewed people, they broke up the people they interviewed into two groups, 13 to 17-year-olds and then 18 to 24-year-olds. And for younger folks, so maybe people are starting to come out younger, is what this shows. Many of them waited until they were older than 13 or older, 66%, whereas the older part of the cohort, 18 to 24-year-olds, a much higher percent, 90 plus percent, waited until they were 13 to come out. So that's that they may or may not share this information with their healthcare provider. And coming out early has some things about it that can be protective. People can receive affirming care and support, but it can also put them at risk for being rejected or harmed based on their sexual orientation or gender identity. Thinking epidemiologically about what our young people are really at risk in terms of mortality rates in the United States, you can see here, and this is very different from older adults for whom heart disease and cancer are the most common causes of mortality. For young people, this graph on the left divides young people into male and female, and the turquoise line is injury death causes for males. Injury includes car crashes, poisonings, which includes overdoses, and other accidents, death from firearms, that are unintentional, but not that does not include uh, self-harm. I don't believe in this graph. Anyhow, you can see that for males, adolescent males, injury is by far the highest cause of death. And if you look at the graph on the right, while motor vehicle accidents, injuries due to transport have come down greatly over the last 20 plus years, the mortality rates due to homicide and suicide and poisoning, including overdose, have been climbing. And these are things we really think of in adolescent medicine as preventable deaths. So these are things that we really want to try to explore with patients when possible and find out what protective factors they have and what we can do to help support them and what we can do to help reduce risks. Here's that data just shown a different way. You can see that the 10 leading cause of death for teenagers are, unintentional injuries, homicide, and suicide, which is really, really tragic. And lastly, I don't think I need to really tell you all this because you've heard about it in the news, but the rate of deaths due to fentanyl and other synthetic opioid overdoses has really shot up in the last couple of years. So that's something that we're all really worried about and working on creating services that are tailored to younger people for. Now, thinking specifically about sexual and reproductive health epidemiology, you're probably all also aware that young people are really overrepresented when it comes to incidence of STIs. So even though this age group 15 to 24, it's roughly about a quarter of the sexually active population, half of new STIs were in this age group. So we really want to be aware of our screening recommendations, making sure young people are, open to being screened with us, and we'll talk about that a little bit more later. So now I'm going to share a little bit of data that's from the Youth Risk Behavior Survey. This is a survey that's administered by the CDC every other year. It's administered in school to students, 9th through 12th grade. So it is a bit of a selected group because it does not include young people who are not in school, are not enrolled in high school or attending school. And the 2023 data have just been released. So this is a nice sort of summary report that was released that includes both some highlights of the 2023 survey and also trends over the last 10 years. So some of the things they highlighted in this report were that for 9th to 12th graders in the YRBS survey, about 3 out of 10 or a little more than that had ever had sex. Only half of those had used a condom the last time they had sex, and only about a third of them used effective hormonal birth control the last time they had sex with an opposite sex partner. So interestingly, you can see here on this graph that the rates of sexual activity have gone down pretty significantly in terms of who's answering these questions, at least for the YRBS, over the last 10 years. And it's both in cisgender males and females. The males is the dotted dark red line, and females is the dotted green line. And you can see here that the changes have been bigger in some groups than others. For Black identified students, for example, rates of sexual activity decreased in that time period by almost 50%, from 61% to 32%. I don't think we have a good understanding yet of why these rates have decreased like this, but perhaps it has to do with shifts in some of those sort of multifactorial things we were talking about in that ecological framework discussion. So hopefully we'll be hearing more theories and ideas about why. In other domains, we see some sort of contradictory changes regarding what are typically considered to be riskier sexual behaviors. So this graph here is young people who had sex with 4 or more partners during their life. And as we know, multiple partners increases risk for STIs. So this is why CDC is looking at this. That has gone down also quite significantly over the last 10 years. But on the other hand, rates of non-condom use have gone up. So this is a graph showing young people reporting that they used a condom the last time they had sex. And unfortunately, as you can see here, that's gone down, quite a bit in the last 10 years for both males and females. And again, I don't think we have good evidence yet to explain, these trends. Looking at contraception, excuse me, in 2023, 33% of high school students overall were currently using, who were sexually active, were currently using a hormonal birth control method, or their partner was. And this is for people who reporting the last time they had sex with an opposite sex partner. So you can see here that there are some pretty significant disparities between different ethnic groups in terms of hormonal birth control use. And that may have to do with sort of a history of reproductive injustice in that community and just lack of trust around hormonal contraception and medical folks recommending it. So I think there's a lot of work for us to do in terms of exploring that and really trying to bring down those disparities and provide services in a more equitable way. The last 2 years, this graph on the right just shows the change over the last 2 years, and it was pretty stable in terms of hormonal birth control use in the last couple of years. So lastly, from the YRBS, if we look at STI testing, again, we see decreases in testing over the last 10 years. And, though some people may have thought this was related to the COVID pandemic, you can see in the bottom graph that this change preceded the COVID pandemic by several years. So why are young people getting tested less for HIV in particular in this bottom graph? I don't know, but I think, again, lots of work for us to think about what's going on in our communities in terms of access and education and barriers to receiving this care. All right, I wanted to just zoom in on STI epidemiology in our age group for just a few moments. This is last year's STI surveillance data from CDC in adolescents and young adults. So as many of you probably know, chlamydia is the reportable bacterial STI that we see most prevalent in teens and young adults. And as you can see here in this upper bar graph, this age group was the most highly affected by chlamydia infections last year, as it has been for many years. You can also see there's pretty significant geographic variation, with the highest rates among adolescents and young adults concentrated sort of in the southeast, depicted in dark blue. Just to give you a sense, since these numbers are really hard to see, of the range, while the rate of reported chlamydia among young women was 700 cases per 100,000 in the state of Maine, it was about 8 times higher than that. In Louisiana, it was over 5,000 cases per 100,000. So some pretty stark disparities there. Thankfully, though we had been seeing an increase in chlamydia rates nationally in this age group up until about 2019, it does look like we're starting to see a decline in both males and females. So hopefully we'll see that continue. For gonorrhea, though it is generally much less prevalent than chlamydia, we again see high rates in teens and young adults, particularly among females, and again with a lot of state to state variation with that sort of similar geographic distribution. Again, the rates vary really wildly. For gonorrhea in Vermont, there were 75 cases per 100,000 young men versus over 1,000. So 75 in Vermont, over 1,000 in Louisiana, and double that rate again in Washington, D.C., over 2,000 per 100,000 men aged 15 to 24. So this may have to do with access to care. It may have to do with sexual networks. There can be lots of reasons for why this is such stark variations, but important to know it's not the same everywhere. Like chlamydia, thankfully, we have started to see declines over the last few years in rates among teens and young adults of gonorrhea. And though this was thought that it could have been due to lower rates of sexual contact and or testing during COVID, these declines seem to be continuing, as you can see. which is really great, especially given the increases in gonococcal resistance to antimicrobial agents. So let's hope these trends continue. And lastly, syphilis. So overall, syphilis does have a proportionately lower incidence among younger folks than chlamydia and gonorrhea. But you can see in this lower graph on the right that we saw big increases in this age group between 2014 and 2021. And also we saw, as many of you know, increases in congenital syphilis, unfortunately. Um, but these do look like also they're stabilizing and maybe coming down. Although you can see in teens, it's more that it's stabilized. In the older age groups, it looks like coming down over the last couple years. Excuse me. So lastly, let's look at epidemiology for teen pregnancy and birth rates. So as you can see, on the upper left, the dark gray line is 15 to 19-year-olds. And the sort of pale teal line towards the top is 20 to 24-year-olds. You can see that the birth rates for both of these age groups has come down quite a lot over the last 30 years. And that's as opposed to the other three age groups this is broken into here, where they've been going up. So the bottom right, you can see that's just 15 to 19-year-olds. And teen birth rates have gone down really, really dramatically since the early 90s, particularly for Hispanic and Black youth. And though this is thought to be, partly due to lower rates of sexual activity that we were looking at earlier in the YRBS data, it's also thought to be due to increased use of more effective contraceptives, such as implants and IUDs. And I'm not going to show any maps here, but there is also, quite a bit of geographic variation, similar distribution with teen pregnancy as with the STI rates that we saw before. And while these are teen birth rates that we're looking at here, teen pregnancy rates nationally have declined precipitously, in parallel as well. And abortion rates have gone down and really have been at their lowest rates for teens since abortion became legal in the country. In 1973, it was 88% lower for 15 to 17-year-olds in 2017 than it had been in 1973. And in terms of IUD and implant use, I don't have a slide for this, but just to tell you, for the YRBS, the increases that were seen in reporting on the YRBS was 1.6% of young people reported using, sexually active young people reported using an IUD or implant in 2013, and that's gone up to 8.9% in 2021. So that is a really big difference and maybe impacting these rates. All right, what about all these other factors and how do we see them influencing sexual and reproductive health for young people? So mental health and adolescent sexual reproductive health, research has demonstrated close associations between depressed mood and substance use and certain risk behaviors such as non-condom use. And on the flip side, good self-esteem, social support, and self-efficacy have been shown to moderate or mediate the negative effects of depressed mood. As we all probably know as well, there was a really significant increase in adolescent mental health concerns during the pandemic that have really persisted. And so, of course, we know these are going to thereby influence our young people's adolescent sexual and reproductive health. So looking at that through the lens of ACEs or adverse childhood experiences, research has also demonstrated that higher rates of adverse childhood experiences or higher scores correlate with much increased odds ratios of high risk sexual behaviors. Sexual minority status is kind of interesting. There's not tons of data about this in the context of broader adolescent health, but this is from a study that was done in the UK. It's called the Millennium Cohort Study of almost 10,000 individuals born between 2000 and 2002. And sexual minority adolescents in this study had increased odds of reporting clinical levels of depressive symptoms, lower life satisfaction, increased odds of self-harm, But interestingly, in this study, they did not have increased odds of engaging in sexual activity in general, nor did they have increased odds of engaging in risky sexual behavior. So sometimes what we may assume to be a risk factor based on adults or other reasons may be protective in certain ways. For gender diversity, this is another area we really don't have a lot of data yet about gender diversity and sexual and reproductive health outcomes in teens. But we do know that our gender nonconforming young people are at very high risk for poor mental health outcomes. So again, that confers greater risk for their sexual and reproductive health. And in the last YRBS Youth Risk Behavior Survey, about 3% of respondents identified as transgender, about 2% identified as questioning. And of those that identified as transgender, about 64% were assigned female at birth. 36% assigned male at birth. So that's a pretty lopsided figure there, which is also very interesting. So just something to keep in mind. How about COVID and its effect? I think we heard lots of different things about COVID's impact on health services in general. And I think we're still really learning about how it impacted adolescent sexual behavior and their access to healthcare services. These graphs are from a really interesting study that was done in Canada that was published this year in the journal Pediatrics. They looked at all publicly insured 12 to 19-year-old females in the province of Ontario. And what they saw was that during the pandemic, there were lower than expected population level rates of adolescent pregnancy and lower than expected rates for contraceptive and STI management. And those encounter rates, that's the gap between these lines on these graphs, did not return to pre-pandemic rates by the time the study ended at the end of 2022, despite their health system really completely reopening. And they did note that pregnancy rates among adolescent sort of subpopulations with the highest pre-pandemic pregnancy rates changed least during the pandemic. So those disparities persisted during the pandemic. And lastly, looking at social media. So this box here is a summary from a really nice review article about the influences of social media on sexual behavior in adolescents. And I will say that though the popular media and academic literature often ring a lot of alarm bells about the dangers of social media and internet use, and among them increases in adolescent consumption of pornography and sexting, I don't think we really know what the impact has been yet overall. And as we've seen in the earlier slides, in the very same years that social media use among teens has really skyrocketed, sexual activity rates have actually declined. And many would argue that social media and the internet serve to fill in gaps in sexuality education for teens that they are not getting in more formal settings, and especially for sexual minority and gender diverse teens. I asked my own 19-year-old about their views about this, and they said that they thought young people were actually much more universally informed about sexual topics than they would be without social media. So we'll really have to stay tuned and encourage more research on this intersection to find out. All right, so I'd like to switch gears now, sort of from those more macro level factors to your actual patient encounters and talk about how you can develop rapport with your patients and obtain an accurate and sensitive, comprehensive sexual history. So a really useful tool for setting the stage for the sexual history is the HEDS exam. If you're not familiar with it, I'll describe it briefly here. But the wonderful thing about the HEDS exam is that it builds from more routine or less intrusive questions to more personal and confidential feeling ones, which really allow you to quickly develop rapport with your patient. I try to do a HEDS exam with my patients at least once a year, more often when needed. And I always start by reviewing limits of confidentiality with my patient. Even if my medical assistant or other support staff have already reviewed it with them, I will still remind them before I start asking questions that everything we discuss will be confidential, but if they share any previous physical harm to them by another person, serious self-harm or suicidal plan, or history of sexual abuse or coercion, I would have to share that information with others. And Of course, knowing your reporting laws in your state is very, very important. And although, reviewing those confidentiality limits may limit what the teen tells me during the interview, it will empower them to make that choice themselves, which I feel is really important for them developmentally, and also just for maintaining trust with them. And just keep in mind, there's no mandate that you have to ask anything in particular, but you certainly have to report that information, once you have it. So you just want to think through those situations carefully. The HEADS acronym has been changed lots of times and adapted by lots of different people. But the most common sort of use of this acronym, H stands for home, E stands for education and employment. There's another E here for eating. Then there's an A for activities, D for drugs or substance use, S for sexuality, another S for suicide or depression, and then another S for safety. So this interview can take 5 minutes or it could take an hour. It really depends on the patient, how much they have to tell you, and your environment and how much time you have available. So you really need to tailor it to both your patient and your setting. But I really find it really enormously helpful in building relationships with my patients, figuring out what their strengths are, really giving them a lot of props for the good, things they're doing and the things that they love to do and what their goals are. And that can also help me sort of point out, through motivational interviewing techniques, what some discrepancies between their goals and what they love to do and what their actions and behaviors, may lead to. So digging into the sexual history part of the interview, I think, again, we just really want to keep that developmental perspective in mind. You want to know your limits of confidentiality, establish them with the patient in advance. Like I said, really want to normalize the interview as part of a broader discussion. Say, I ask all my patients these questions. It's really great to conduct this interview while the patient is still dressed. If you're in a sexual health setting, a lot of time patients are undressed by the time we get in the room, or if they're in for an annual physical exam, and it can make it a little less comfortable for them. You want to really try to minimize note taking while asking these sensitive questions and really do active listening with eye contact. And then just make no assumptions about your patient's gender identity, their sexual orientation, or their sexual experience. And we really want to try to use language, gender neutral language. So some of you may know or be familiar with the 5Ps sexual history mnemonic from the CDC. The National Coalition for Sexual Health has added on a 6th P or plus, and we'll talk about how we can incorporate all of these into our sexual history with adolescents. And some of the content I'm going to be sharing comes from a sexual health education program I was involved in for many years. That's now available on the Advocates for Youth website. And those are slide sets that anybody can download and use if you like to teach other people. So you can see the website in the bottom right corner of this slide, and you'll see the Advocates for Youth and their Amaze logo on some of these slides. So first, in the sexual history, I always ask young people about their gender identity. What is your gender identity? Most young people now are pretty used to this question, so it doesn't strike them as a strange question to ask. And what pronouns do you use? What genders are you attracted to? And are you attracted to anyone currently? So that can just sort of help open the conversation and know where we're starting from. Or partners, so the first P. Have you ever had a crush on someone? What was that like? Have you ever had a romantic or sexual relationship with someone? How did that go for you? Are you in a relationship now? How is that relationship going for you? And does your partner make you feel good about yourself? What do you think are the strengths of your relationship? Does your partner ever make you feel bad about yourself or try to control you? So just thinking about through with a patient, what are the good things about their current relationship if they're in one, and what is not, and what their goals are can also really help support them. Sexual behavior history questions, so practices. So of course, we're going to tailor this depending on the patient's age, and you're going to frame these questions differently for a 12-year-old than you would for an 18-year-old. But for a younger patient, you might say, there are many ways of being sexual or intimate with another person, and these include kissing, hugging, touching, having oral sex, vaginal sex, or anal sex. And have you ever had any of these experiences? And if they say yes, I will often ask, how many sexual partners have you had in your lifetime? What about recently in the past 3 months? What about in the last year? And when was the last time you had sex? Which, especially if they have the capacity to become pregnant, becomes very important, because if it was recently and they did not use a condom, we can talk to them about emergency contraception, assuming they do not want to become pregnant. And then I always ask people, when you've had sex, has it been your choice? Have you been there because you want to be there? Protection from STIs. So I ask patients if they're sexually active and have already had vaginal or anal sex, how often do you use a condom to use protection to protect against STIs and pregnancy? I'll ask them, like, what percent of the time? Most of the time, 100% of the time, some of the time, none of the time. And depending on their answer, I will ask, what determines whether you use a condom or not? How do you decide with that particular partner? Is your partner willing to use, or partners willing to use a condom? And did you use a condom the last time you had sex? For past history of STIs, have you ever had an STI? How long ago was that? Did you get treatment for it? Did you finish your treatment? And what about your partner? And would you like to be tested today? And as all of you, I'm sure, know, there are really easy ways to do STI screening now that do not require an exam in most cases. So just as a quick reminder, STI screening and prevention recommendations for adolescents and young adults from CDC and USPSTF recommend that all sexually active females under 25 years be screened annually for both chlamydia and gonorrhea, that all sexually active young males who have sex with men be screened at least annually for both chlamydia and gonorrhea. The HIV testing should be offered to all adolescents, and the frequency depends on your local epidemiology and the patient's behaviors, and that young MSMs and pregnant females should be routinely screened for syphilis. In terms of prevention, HPV vaccination, hepatitis A and B vaccination are recommended for all adolescents and young adults if they hadn't been vaccinated during childhood. And then HIV prevention, including PrEP, should be discussed and offered to all young people who are at a higher risk for HIV. And we think about that really as any patient that's had a bacterial STI in the last 6 months, as well as people whose partners are living with HIV, people with multiple partners, exchanging sex for money, other things that may increase their risk for HIV. Pregnancy history and prevention. So have you ever been pregnant, or have any of your partners ever become pregnant? Do you want to become pregnant anytime in the near future? If not, what are you doing to prevent pregnancy? If patients tell me they do want to become pregnant, although that may be challenging for lots of different reasons, I'll talk with them about, minimizing substance use and taking, prenatal vitamins. But if they do not want to become pregnant, which is the case with most teenagers, I ask them if they've ever had a scare, a near miss, have they ever taken emergency contraception, or how many times have they, if they've used it, and what other methods of birth control have they used for pregnancy prevention. If they are interested in talking about birth control, which of course is a whole independent topic, and we could spend a very long time talking about just that, I ask them, what's most important to you in a birth control method? Is it that it be extremely effective, the most important thing? Or is it, for example, that it not change your period? Is that the most important thing for you? Is privacy, a very private method, the most important thing for you? It is really different for different teens. And then I'll ask them if they would like me to share more information about the options that we have available. Screening for substance use during sexual activity and screening for sexual violence is unfortunately very important. So, so I will ask patients if they ever drink alcohol, get high, or use substances before having sex. And if so, how are they working to keep themselves safe? I ask them if anyone else has ever encouraged them to drink or get high so that in order to have sex with you. Has anyone ever forced you to do something sexual that you didn't want to do or touched you in a sexual way that you didn't want? And if so, did you talk to anybody? Has it been reported? Have you ever talked with a therapist or counselor about these experiences? Of course, this is going to take, make your interview a lot longer if someone answers yes to these questions, because we do have to report that information. And most importantly, make sure that the young person has support. And then the 6P that got added. So that can include pleasure, problems, and pride. So I really try to ask all of my patients, and especially teenage girls, if sex is fun and enjoyable for them. I think a lot of teenage girls think that they're not supposed to want to have sex, or that it's, only supposed to be enjoyable for their partner. So I really try to support them and say this, you should only be here if it's fun for you, right? Are you and your partner communicating well? If you're not having sex, but you want to, are there experiences that have happened to you in the past that you think are getting in your way? Are you having pain during sex or difficulties with your sex drive that are interfering with your relationship or ability to have sex? And then for young folks who are LGBTQ plus, I will ask if their friends or family know about their gender identity or sexual orientation, if they know about a relationship that they may be in, and are they supportive? And especially if they say they're not supportive, then I try to work with them on resources and counseling that can help provide that support in the absence of family support. So thinking about all of that and how we would counsel teens around sexual health issues, it's really important that we really think about the young person in front of us as goals for their reproductive health. And we want to center, like we talked about, their sexual well-being in a sex positive way. We really want to take into account their strengths and knowledge and their life experiences and how all of that is informing what they're doing now. I think this really requires reflection of our own and exploring our own biases and how we feel about teens and sexuality and teen and pregnancy and teens and condom use and all of those things, because sometimes we're not totally aware that we may be presenting things to our younger patients in a biased way. And we really want to incorporate a sort of positive youth development framework rather than centering a risk-based approach, because the just say no approach, as most of us know, doesn't work very well. But when we think about a young person's aspirations and goals and what we can do again to sort of scaffold that, and how we can link that together with the choices they're making currently, that has been shown to be much more effective. I wanted to share a couple counseling and educational resources. There's so many out there, but here are a few. This first one for client-centered contraceptive counseling, it's not designed specifically for teens, but I think it can be used really effectively for teens and young adults, and just has some key questions around contraception counseling. It's a really fabulous handheld tool that was developed at the University of Chicago that you can purchase online, that has all of the different available contraceptive methods that we have mocked up, and you can show them. They're kind of real life size, a birth control pill pack, a ring, an IUD, to show to a patient. I have one of these that's really great. Wonderful graphics that go through very basic information. This one is from CAI Global around birth control methods and where they go in the body and how they work. The Center of Excellence for LGBTQ plus Behavioral Health Equity has excellent training modules and materials for making your environment trauma informed and welcoming to LGBTQ plus young people. Advocates for Youth, like I mentioned, has great resources both for providers, and then Amaze is for young people and their families, are really awesome. And then the National Coalition for Sexual Health has really wonderful resources with different messaging tools and quizzes that can be used as well. So lots and lots of resources out there, and you can explore, some of these to see if you find them helpful. So in conclusion, I want to circle back to teen-friendly health services. Given everything we've talked about, teen-friendly services should be adolescent specific, developmentally oriented whenever possible. You really want to think about your staff at your clinic from the very front desk all the way to the back. Do they like teenagers? Are they friendly to teenagers? Have they been trained to work with young people? Are you part of a network of youth services that you can refer young people to? Your services should be equitable and welcoming to all teens in your community and have language services if needed, should be welcoming to LGBTQ positive youth and youth from all different ethnic and racial backgrounds, should be proactive about confidentiality and consent for young people, hopefully low barrier cost-wise. You should have youth-friendly hours, have trauma-informed staff, and support communication between teens and their caregivers. So I know it's a lot, but I think these are things we can all aspire to as we work to provide really excellent services to teens and to promote their sexual well-being. So that's all I have for you in terms of content. And I'm going to end the slideshow here and turn on my camera. One moment. Oops.
Okay, we can see you now. Thank you.
Great.
Thank you so much for that whirlwind of information. We do have a lot of questions coming in the
Great.
chat. Would you mind if I share my screen again, just to put up a reminder about the CME information for folks
Of
who might be
course.
curious about that? Okay, I'm going to do that. Actually, if you can stop sharing, that would probably be
Oh,
easiest.
did I not stop yet?
We can still see your desktop
See.
background.
Oh, whoops. Hold on a minute. Stop share. That's so weird. Does not show me as sharing.
There we go. All good.
Yeah. Okay.
Yeah, it's fine. All right, just give me 1 second to pull this up. But while I do that, I'm just going to start in the questions. So the first question that we had was honestly a bit more of a comment, but it was about a lot of the rapid HIV tests say that they're indicated for people who are 13 and older, which led me to think about, some of these over-the-counter and rapid tests for HIV and STIs are also becoming available, and I don't know if there's any sort of age limit that would be applied to them, or if anyone can just sort of like buy them at a pharmacy. So not asking you to have all the answers there, but just curious if this has come up for you or how you think about like rapid or point of care tests in young people.
Yeah, that's a great question. I mean, I suspect this is not my area of expertise, but that they've been validated, for certain age patients, both for their capacity and ability to use them properly, to read the instructions, to do whatever they need to do to use them appropriately. I don't know, right now it's so hard with pharmacies keeping things, locked in cabinets anyway. I think that's intimidating for people of all ages to go in and have to ask someone for anything confidential, in the confidential realm to ask someone, staff to open up those cabinets for you. And I'm guessing these tests are behind that firewall. So it is a really interesting point. I don't know that that means that younger kids couldn't use them, but I have a sense, feeling that the companies have just validated them for those particular groups.
Thanks, that is helpful. And yeah, I think especially in, well, some of the pharmacies in San Francisco, like everything is under lock and key, it feels like.
Yeah, it's really
So that
challenging.
could certainly be a barrier for
Yeah.
sure. All right. There are more things coming in the Q&A. The next one is, there were actually a couple questions about some of the youth risk behavior surveys that you showed. And probably the easiest thing would just be like, do you know how people can access them? Because people had questions about, is this only for schools that receive federal funding? Do we know like the numbers, the ends, numerators and denominators, that sort of thing? So
Yeah.
I don't know if you
Yeah.
know those offhand or just can let people know how to access those surveys.
Yeah. All of the YRBS data is actually publicly available. Over the years, I think probably based on its own resource availability, CDC has done different things in terms of how they've presented the data. Some years they've made slide sets that we can use to share the data with folks, and other years they haven't. I didn't see any slide sets yet for 2023. But all of the raw data you can actually access on the CDC website. And then there are MMWR reports that have been written that break out the data in different ways. So we could maybe share that when we send out the course materials, but there is a whole, page and area on the CDC website for accessing YRBS. As far as who participates, so I believe that there are some states that do not participate in the YRBS, but most do. And in their, usually for each year that they administer the study, they have sort of a document on their methodology, and that will go through like how they captured the data.
Mhm.
Did they go on just one school day? Did they go on multiple school days? Et cetera. And then what jurisdictions or areas participated.
Great. And I know many of your slides had sort of links or references at the bottom, so I'm
Yeah.
imagining you may have linked the survey
Hmm.
in that way too for folks
Yeah.
who will be receiving these slides, which is
Yeah.
everybody who registered for this webinar. You'll be getting the slides in 2 weeks. Okay, next question. I liked this question and certainly don't know the answer myself. Are there social media channel recommendations that you have to share with youth when you're discussing things like safe sex or consent or healthy relationships?
That's such a good question. And despite the fact that I'm an adolescent medicine provider, I do not subscribe to TikTok,
Oh no.
nor various other major social media platforms. I have to ask my kids about a lot of that stuff, and I really should. But the one that I mentioned, Advocates for Youth, Amaze curriculum is really great. I think it's targeted a little bit more to younger kids than older teens, but that's super high quality information. Um, excuse me. And then, I think this is such a challenge in general, teaching young people, social media literacy and how they can, determine and discern if the things coming through their feeds are reliable or not. So I don't have any, but I imagine there are resources out there to help direct providers to areas online that they can direct patients to.
Great, thank you. Okay, there's more. Are you up for some more?
Yeah, of course.
Okay, I think this is a really good question too, and sort of in the era of open data in the EMR and people being able to access their own and others like written documentation. So the
Mm-hmm,
question
mm-hmm,
is, what do you recommend telling your adolescent patients about what you've written on your
yeah.
appointment with them? So there's
Mm-hmm,
context here. And the context is I have some patients that are really sensitive to knowing what they tell me and whether or not it's documented in writing. And at the place where this person works, they're saying patients can see the notes we write online after the encounter.
mm-hmm,
And technically, staff who are in the charts could see these notes too. So, just about
mm-hmm.
that confidentiality piece in terms of like what's in the EMR and who can see it, and how do you talk to teens about that?
Yeah, yeah. This is a really important question, and there is some work, that's been done on sort of the age of the EMR and adolescent confidentiality. There's a center at UCSF that works on that. So it really varies. And of course, like my chart, there are certain EMRs that go across hospitals. It's not even like in your own center, but providers from other places may be able to see what's happened, in your visit at another institution. So it is a really, really important question. If patients ask me, I tell them I have to put in the critical elements of our conversation in our note because it's the way that I will know the next time I see you what we talked about. So I don't have to ask you every single thing over again. Test results, of course, go into your chart. And in California, we do have the ability to request that EOBs not be sent home. So that's something that clinics should be aware about. You can help young people. There's a form you have to send into their insurance company. I never know how reliable it is or how quickly they will turn that around. but at least for folks with commercial insurance where EOBs are sent home, those can be suppressed. For people with Medi-Cal does not usually send itemized EOBs home, so that makes it a little bit less risky feeling for them. Um, and yeah, it's a really tricky thing. Some EMRs have, flags on confidential type notes so that they will not get printed out with the rest of the chart. Um, and um, and then for patients who are really, really, really worried, like if there are primary care patients here at CHLA and they really want to absolutely reduce the risk of anything being seen by their parents, which is really hard to promise. But I often will recommend that they go to a different, to a dedicated sexual health clinic, like a Planned Parenthood clinic, because that's a completely different system and nothing is going to get sent home from there. So I hope not to, I mean, it's wonderful if they want to go to Planned Parenthood, but we really want to be able to offer them the services on the day of when they're here. But there are some young people who really, really have, really particular concerns. So we try to just review the options with them and what's realistic.
Sounds good. Tricky area. And there's a couple
Yeah.
other questions relating to this in the Q&A, which I'll just kind of feed to you now to see if you want to build on what you've already said around the
Mm-hmm.
EMR.
Mm-hmm.
There's sort of like two questions, but they're very similar. How do you recommend delivering a positive STI result to a teen? Do you do it with
Mm-hmm.
them alone or if their parent is present? And then a similar related question, what do you do in the event that, like, no matter what you want to do, the parent decides that they want to be in the room and they're going to be in the room? And like, how do you navigate that
Yeah,
scenario?
yeah, yeah. We
Delivering
talk
the
about this
results and
a
yeah.
lot with residents and trainees. So we cannot ever force a parent to leave the room. So that's not something we're going to do. But I do often, especially with parents of younger teens, I really try to build an alliance with them and I really try to frame it in a more positive way and say, learning to talk to a healthcare provider is a really important task of adolescence and young adulthood, right? You do not want your kid to be 40 years old and needing you to go to the doctor with them in most cases, right? That would not be healthy. So this is like another developmental milestone that we want to work on together and help your kid learn to talk to us. And also sometimes I will say like, the same patient and parent where I will ask the patient questions and they look at their mom or dad instead of answering me because they're very shy or they don't want to say something. And the mom and dad will say, you tell them, I want you to say it. You don't need me to talk for you. Sometimes those same parents are the ones that don't want to leave the room. So I will say, this is part of them learning those skills of speaking for themselves. Sometimes it's easier for them to talk or ask questions on their own, and also this has been really established as a normal necessary part of adolescent healthcare. And often if the parents are not like game and willing to do that on the first visit, as I build rapport with both of them over time, I can just sort of keep nudging them and reminding them and saying, what do you think? Don't you think they're ready now? Like, how
Mm.
about we try that? You really can't, I mean, you cannot give an STI test result with a parent in the room. You really can't, because the kid has to give consent for you to release that information in California, at least to the parent. So if the parent will not leave, hopefully you have in your intake process in your clinic obtained other information, and most clinics seeing teens really should work on that. Getting an email address, a cell phone number, something that's specific for the young person that can let you work around that. And then lots of EMRs now require, a 12-year-old and up to have their own access to their account. There's ways parents can work around that with proxies and all this stuff, but we really should, if we've been able to order a confidential test for a patient, then we really need to have some way to talk or communicate with them independently to give them the result.
Yeah, I think that's a really good workaround, sort of framing it as like a developmental step for the child. And don't you want your child to take that next step? I think
Mm-hmm,
that's
mm-hmm.
really smart. I wouldn't have thought of it. I like that one a lot. I did want to just kind of circle back to what social media resources are available and really just share what people are putting in the Q&A. Again, I really can't, I've not vetted any of these, but just to say them
Yeah.
out loud, folks are recommending a book on consent by Dr. Drew Pinsky and Paulina Pinsky. Some folks are saying they like at giving the talk on Instagram a lot. Somebody who's a sex educator and mom, Dr. Emily Morse, having resources for youth on Instagram and the Sex with Emily account. Again, not ones that I can vouch for myself, only because I'm also not active on TikTok. I think I've aged out. But thank you all for sharing those tips and tricks in the chat. Or the
Dr.
Q&A
Drew
rather.
Pinsky, by the way, I don't know if anyone is old enough to remember Dr. Drew, the radio show and TV show for many years ago, but that's the same guy. So he's been working in this area for a long, long time.
Awesome. Oh, somebody else says Scarlet Teen website also
Oh yeah,
good.
I have heard about Scarlet Team. Yeah.
Okay, now back to questions for you. This is one. It's kind of funny. It actually made me laugh a bit. This happened when you were talking about some of like the heads analysis and all the questions that
Mm-hmm.
you can ask teens.
Mm-hmm.
This is the quote. This is a lot of information and so many questions. Honestly, on average, how long does it take you to do an appointment with a teenager?
Yeah, well, again, this all depends on your setting, right? So if you're doing an initial physical exam in a primary care setting, hopefully, especially if you see a lot of teens, you have a little bit of extra time on that exam. And if you have your next point, person is waiting at the door to see you, or in the waiting room. And you can really sort of trim the heads exam and do the most essential things that you feel like you need to do during the time you have alone with the patient. Like I said, you could take an hour, you could take more asking all those questions. You don't have to do them all on the same day. You can start with just
Mhm.
one aspect of the heads exam and move through it each time you see the patient and build the rapport slowly then. I think the main thing is that if something is going on with your patient that is setting off, alarms for you, that there could be something going on. Either the parent is saying there's something wrong, my kid is using drugs, the kid is having a stomach ache every single day and not going to school. They've been losing weight rapidly, any of the things that would indicate to you that there could be some degree of harm going on, either self-inflicted or by somebody else. You have to take some extra time with that kid, right? It is just going to take some more time. And this is a tool you can use that may help you have a more productive, conversation and visit with them. But there is no, like I said, there's no mandate or requirement that you ask any of those questions. It's really just designed to help you get to those more sort of tricky confidential pieces and build trust.
Got it. Okay, another question about logistics of appointments with teens. Please define teen-friendly hours, smiley face.
Oh yeah, well that's a great question, and I can't say that my current clinic where I work has teen friendly hours, but I do think it's something that can be really helpful. So staying open till 6 or 7 p.m. so that kids don't have to miss school is extremely helpful. Not to mention for their parents, who we have to see kids with their parents unless it's for a confidential reason. So if they're coming for general primary care, they have to come in with a parent. um, Being open on a weekend, Saturday morning can be super helpful. Having virtual, telehealth appointments available is also really super helpful. In California, schools are required to release students without telling their parents if they have a confidential health appointment. So if a patient has a sexual health appointment, off campus, not at their school-based health center that they need to get to, their school may not know this, but they are required to let them go without giving them
Hmm.
an attendance ding and without calling home, which, in LAUSD, there's like robocalls that go out to families every time your kid misses a class, which I know from personal experience. So it's fraught, but that's actually legally required. So that's also something we can educate patients about, is that if they have a way to get to you on the bus or other public transportation, they are technically allowed to leave school, but extended hours are really helpful.
I did not know that about the schools. That is
Mhm.
interesting. I think another logistic question. We are getting to the end here, by the way, so you're almost done.
Great.
um, but next logistic question: do you know, have teens been able to self-consent for HPV vaccines since the vaccine first came out, or is this something new?
It's not since the vaccine first came out. I think it's 2011, and this is just California. I don't know about other states. Prevention of STIs became a minor consent service at the age of 12 and higher. So I can't remember what year the HPV vaccine started to be widely available. But that's when. So that little chart that I had showed, I had actually added prevention onto that because that chart was from 2010. It was from before that newer legislation went through allowing prevention of STIs as a minor consent service as well.
Got it. Okay, thanks for that clarification.
Mhm.
And then final question that we've got right now is speaking to primary care providers. Uh-oh, we got another one popping up, so might be last two. I don't know. I don't want to promise anything, but here's the next one.
Yeah.
What advice would you give for educating or encouraging primary care providers who are not routinely evaluating sexual health in adolescents to do so? This person says baby steps would be crucial for acceptance and participation from providers.
Yeah.
What, if any, tools or resources would help primary care providers integrate sexual health evaluations into something like annual wellness exams?
Yeah, it's a good question. And I think it really often comes down to time. So primary care providers have to do a lot of things at their primary care visits with teenagers. But the AAP and Bright Futures does recommend assessing young people annually, starting at age, I think it's 11 or 12 for STI risk. So, and that really means an AAP has said it's required spending some time alone with patients. So starting to help, general pediatricians, family medicine folks who, and other providers who are seeing teenagers, um, try to build that into their practice. And the other thing is comfort, right? I think a lot of people that take care of younger patients, they love babies, and that's who they went into. Maybe it might be pediatrics or pediatric nurse practitioners, tracks. And they're not, so crazy about talking about teenage issues. So working with them, finding out if that's the case. If it is, do they want to start transitioning their patients, to a different person in the office who's more comfortable with those patients? And if it's not a comfort thing, it's more time, then helping them learn how to do some of those things efficiently and just as a normal part of their practice, just like they would go through other anticipatory guidance or vaccine recommendations. But there's no simple way. Yeah.
That's an interesting angle, though. I like what you said about each of us sort of thinking about like who did you go into your practice to see, and if it's not the patients that you're seeing, how can you transition them to somebody who might better serve their
Yeah.
needs? That makes a lot of sense to me. I certainly would not personally feel very comfortable taking care of a baby, given that I'm an adult provider.
Right.
And I think some adolescents are probably ready for that more adult type
Mm-hmm.
conversation.
Mm-hmm. Mm-hmm.
Okay, next question. And I don't know what your thoughts will be on this one. It's more about policy, actually.
Mm-hmm.
But do you know if providers in more sex positive states have teamed up with providers in less sex positive states to try to translate some effective methods to a more conservative setting? It's a great question. I
It is.
personally don't know exactly how to speak to that, but do you have any thoughts?
Yeah, I mean, honestly, I started putting this presentation together before the election, and as we all know, there's just been a lot of rhetoric and talk about, reproductive health rights, gender issues that are really going to impact our patients in big ways potentially in the next few years. And it's really hard actually to compartmentalize and not think about that all the time. And we have partners in other states who really struggle with this already. So I think looking to national organizations, for ways to partner with folks is really, really important. Um, but I think it's a struggle, and I don't have an easy answer for that. I think we should all reach out if we can to friends and colleagues in other states. Yeah.
Yeah, I think a very challenging issue because
Yeah,
policymakers in the more sex positive states may feel very differently than
yeah,
policymakers elsewhere, and
yeah.
maybe hard to figure out how to get on the right page. But I will say, if you're looking for resources for your friends and family, this webinar will actually be posted on the CAPTC website and will be emailed to
Great.
all of you who registered. So feel free to share it as a helpful resource. And you are getting lots of kudos in the Q&A, by the way. Excellent
Oh,
presentation. Thank
good.
you for sharing. So informative. Can't wait for the slides. All of these are happening. All right,
Great.
one last question from the Q&A, which is about transgender care. And we have had separate webinars on this topic, but can you confirm that transgender care does not fall under minor consent laws? In other words, do parents have to consent for transgender care? Do you know?
Right, right. So, in most states that as far as I am aware, for gender affirming hormonal treatment or surgery, parental consent is required and is sort of the standard of care. So, talking about gender identity does not mean that you have to go tell a parent, but if you wanted to prescribe a medication or operate on someone for gender affirming care, as far as I understand, and I'm not a gender care, expert, but we have a huge center here, and we involve parents for consent for anything around hormonal prescriptions or surgery at CHLA. Most of the surgeries are not on minors, um, so parental consent is critical, and I think people have to go to court if they want to try to sort of bypass parental consent. It's required.
Got it. Okay. Well, thanks for that. So we've answered everything in the Q&A. I have one more burning question for you if you have one more minute.
Sure.
Okay, wonderful. Actually, I'm hearing that we're over time, so please feel free to leave if you guys need to. I'm going to ask my last question to Claudia, if that's all right with you. Sounds like you have a few more minutes.
Yeah.
But this was just something that was occurring to me. You were showing the 2023 STI surveillance trends and kind of showing how,
Hmm.
oh, wow, things are starting to turn the corner in 2023,
Hmm.
like chlamydia and
Hmm.
gonorrhea rates coming down. Very encouraging. On the adult side, one of the theories about why this might be happening, among many, certainly not like the
Hmm.
be all end all, but the availability of doxycycline post exposure prophylaxis, both
Hmm.
for individual patients and for sexual networks, has been
Hmm.
posited as a
Yeah.
potential contributing
Yeah.
theory, which made me wonder how and if doxypep is being talked about or offered to
Yeah.
adolescents, and if you think that's playing into this trend, or if there are other factors at play, which is undoubtedly the case. It's probably next
Yeah. I'm sure
research
it's
you're
lots
in.
of factors. In adolescent medicine circles, we are definitely talking about doxypep and offering it to patients that would, benefit and are interested. Um, I can't say that I think, where the majority of teens get their general primary care, that's happening, but in clinics and, Planned Parenthoods and STI clinics and adolescent medicine clinics, we are definitely talking about doxypep with patients, especially those who have been diagnosed with an STI recently. So hopefully I would be surprised if that was, a big part of why those rates have gone down, because I just don't think it's very common yet for
Yeah,
younger patients to take
yeah.
doxypep, but it would be great if that's part of why.
Hmm. Interesting. Okay, well, I know we're over time. I'm sorry to have gone a bit over. I just had to get that question answered. Thank you so much for being here and giving this super phenomenal talk. And thank you all for attending and being here. We appreciate you all and hope to see you at our next training. Until
Thank
next
you.
time.
Thanks,
Bye.
everybody.